Hello everyone. Today we'll be discussing the basics of doctor-patient communication and we'll practice a few exercises which can be applied in a setting of clinical pharmacology. So I want you to understand that this is the very basis of a healthy interaction between a physician and a patient, and finally, which brings about positive implications on the clinical care. It's very important that these aspects be understood well because they can bring about success to whatever pharmacotherapeutic uh, goals we carry. So let's start. All right, so let's begin with the discussion. Here on the slide, you can see I've mentioned something called 6 points of minimum information to the patient. So basically, this says that your patient needs to know at least 6 points about whatever treatment he has been given. Okay, uh, this goes without saying that obviously the first part of the communication with the patient is going to be understanding the patient, understanding his symptoms, finally coming up with a rational therapy, a pharmacotherapy, and then whatever instructions you give to the patient is what I have listed down. So the first instruction is going to be about the effects of the drug. Now your patient needs to know what this drug is going to do to him, at least an overview. You don't need to tell him the entire mechanism of action, but he needs to know. For example, if you are prescribing a patient who is an he's an hypertensive, so you're giving something which is going to be an antihypertensive. For example, you are prescribing this patient with something called as diuretics. You know diuretics, right? What they do is they increase the frequency of urination, they increase the urination, they cause sodium water loss, and so it will reduce the volume overload inside the blood vessels of the patient, and there will be reduction in blood pressure. So what will you tell the patient? You will tell the patient that you have been diagnosed with hypertension, and so we are prescribing you a drug which is an antihypertensive. It will increase the frequency of your urination, it will increase urination, and will bring down the blood pressure. So do not get apprehensive if you start frequently urinating or urinating more. So this is about the basic idea of the effects of the drug and what it is going to bring about in the patient. All right. So once you're done with telling them the effects, you need to tell them something called the side effects. For example, uh, again in the same case, for example, in the diuretics case, you know that they cause potassium loss, they cause hypokalemia. So one of the side effects could be muscle cramps, and mild muscle cramps can be seen with any thiazide diuretic. You need to tell the patient that you may experience muscle pains, muscle cramps, and that is absolutely normal for this drug. But if in case it is excessive or beyond tolerance, your tolerance capacity, then you may have to come back and report it to me. Okay, then the third point is about the instruction for use. Now, what do you mean by instruction for use? It's basically about the route of administration, the time which is to be taken, and for what duration, for how long it has to be taken, and stuff like that. For example, if a drug has to be taken in the morning, or if it is to be taken in the night time before bed, or it has to be taken before food, or it's to be taken after food, what you should not take along with the drug, and you have to take it for a complete week or for 2 weeks or for 2 months or 3 months. So that's basically what is the instruction for use. And that is a very important point to consider whenever you instruct a patient regarding any particular therapy. All right. Now the fourth point. Fourth point is very, very important, which is regarding warnings. What do you mean by warnings? You've already told him the side effects. You've already told him the instructions of usage of the drug. Then what do you mean by warnings? So the warning basically can go on two lines. One is when to stop the drug and when not to stop the drug. As you can see here, when not to stop the drug and when to stop the drug. Let's start with when to stop the drug related warnings. So here you can see that there is a drug called oxymetazoline, if you know. It's a nasal decongestant. You use it for stuffy nose whenever you have, allergic rhinitis or rhinitis because of changing seasons and stuff like that. There is stuffy nose, nasal obstruction, difficulty in breathing, and that's the patient's complaint with which he comes to you with. So you might prescribe him with nasal decongestants, for example, oxymetazoline, silometazoline, and stuff like that. If you know the common brand name called Otrivin, yeah, Otrivin, it's the same drug. So what is important to know that this drug called oxymetazoline is an adrenergic agonist. It is an adrenergic agonist, okay, alpha 1 agonist. And what it causes basically in your nose is that if I want to tell you that this is your nose and inside the nose there is the mucosal lining, okay, and in the patient who has a complaint of nasal congestion, he has difficulty breathing, his watery nose and stuff like that. It is because his blood vessels inside his nasal mucosa have got dilated, and since they have got dilated, the fluid is coming out and it is causing edema in the mucosa, and that is causing all the symptoms in this patient. So when you give this drug called alpha 1 agonist, oxymetazoline, what it causes is it vasoconstricts this blood vessel. It will decrease the lumen of this blood vessel. It will bring about vasoconstriction, and it will resolve the edema. And that is what the drug does. But if you give the drug beyond 4 to 5 days or maximum 7 days, you can take the drug only for less than equal to 7 days. If you take it for more than this period, what happens is there is something called as a rebound phenomenon. Okay, what is rebound? Rebound is that the drug now stops its mechanism, it stops its action, and again the blood vessels will dilate, again there will be congestion. So here you need to tell the patient that once after 4 days, when your symptoms are normalized, you have to stop the drug. And finally, when the season changes or whenever the allergen is taken out, your symptoms will automatically resolve. You don't need to continue the drug for long because it can be harmful if it is taken for longer time. Now, the specific condition is also called as rhinitis medicamentosa, which is edematous mucosa because of excessive use of this drug. Okay, now the second thing which comes here is about when to stop the drug. When to stop the drug related warnings. When not to stop the drug. I'm sorry. When not to stop the drug related warnings. So here you have an example of the same patient, the previous patient, was prescribed with an antihypertensive drug. Now he needs to know, you have to tell this patient that antihypertensive drugs are given to bring down the blood pressure to normal and has to be taken for a longer duration of time. It takes time to bring it to normal, and also it has to be maintained to a normal BP for longer period of time. Now, why do the patient needs to know this? Because he might think that now his symptoms have resolved or whatever, he will stop taking the drug, or maybe he thinks that the drug is not working, so he stopped taking the drug. You need to tell the patient that it will take long that the drug starts showing its effects, and you need to maintain the pressure for a longer time because high blood pressure can be damaging his internal organs, his kidneys, his heart. That is important to take this drug for a longer period of time. Similarly, the second case is about steroids, corticoids. Corticoids are similar chemicals which are also released by your adrenal glands. Now, why do you give them exogenously? You give them exogenously in certain cases, for example, in cases of autoimmune disorders. So, in autoimmune disorders, we aim to suppress the immunity of the patient for that particular period of time so that the symptoms resolve and the condition resolves. And for that, we give them steroids. Now, when you give them steroids exogenously, the ACTH inside starts falling. What is ACTH? Adrenocorticotropic hormone. So the body senses that you have enough steroids in your blood, so you don't need to uh, ask the adrenals to produce any more. So the ACTH starts falling, and now you have a low level of ACTH in the body. Now, what happens if this patient suddenly stops the drug? He suddenly stops the drug, and there is no steroids at all in his body, and the ACTH is also low. So the adrenals are not able to make enough steroids for the body, and the steroids are very essential. A basal level of steroids is essential for the body to function. It is a crisis controller of your body. So it's very important that your adrenals at basal level keep producing some amount of steroid. And if there is suddenly no steroid in the body, no ACTH, then you can go into an emergency called as adrenal crisis. So this is what the patient needs to know. He cannot stop steroids. He should be told that he can land into an emergency. He has to stop the steroids only with the doctor's consultation. Okay. So these are an overview about certain warnings a drug uh, comes with and what the patient needs to know. All right. So let's talk about the next point. The next point is a simple thing which is about the future consultation, but it's also very important because when you instruct a patient, maybe for example, in the initial case of a patient who has been recently diagnosed with hypertension, just like the previous examples you've taken, now we have given him a diuretic and we have told him to use it for about 1 month, to take it for 1 month, and we want him to come back after a month. Now, we tell this patient that you have to come back after a month so that we can assess your blood pressure. If it has come to normal, you can continue the same drug, or if it is not coming to normal, maybe I will have to change with something else. So, that is about the future consultation. The patient needs to know why he is being called for a future consultation and stuff like that. Alright, so the sixth point. The sixth point is regarding the confirmation. Now, what do you mean by confirmation? Confirmation is nothing but you will ask the patient, is everything everything clear? You will ask the patient if he understood what has been, uh, you know, instructed. You'll ask him, what do you understand? What do you know about the instructions? When did I tell you to take the drug? So, what are you going to be careful about? And you just repeat the things for him so that he's confirmed with every instruction and there is no doubt regarding it. May take a few more minutes, but it's very important that the patient has completely understood and is not overwhelmed with all the instructions. Alright, so let's start with our sample cases. So here is the first sample case. It says to provide instructions for a 45-year-old male patient with open angle glaucoma regarding the use of temolol maleate eye drops. So the drug here is temolol maleate, and the patient is diagnosed with a condition called glaucoma. Before coming to the drug and its instructions, I also want to superficially give you an overview about what glaucoma is in case you don't remember or don't know. Glaucoma is something with increased intraocular tension in the eye. It's a condition with increased intraocular tension in the eye. And why does that happen? Let's see here in this diagram. It's from the KDT Essentials of Pharmacotherapy. Uh, you can see, I'll tell you about this area. Okay, what is this called? This is called the ciliary body. And the ciliary body is responsible for production of aqueous humor in the anterior chamber of the eye. What is the anterior chamber? The entire part in front of the lens is called the anterior chamber, and the fluid is produced from the ciliary body. So the ciliary body will produce this fluid called aqueous humor. It starts flowing in between the lens and the iris and comes in the anterior segment. So the part posterior to the iris is called the posterior segment, and the part anterior to the iris is called the anterior segment, and this entire thing together is called the anterior chamber. So now it comes in the anterior segment, and from here it is taken into the Schlemm's canal in the trabecular area, from where it is absorbed back. So the rate of secretion is equal to the rate of absorption. A little amount of this aqueous humor is also absorbed from the scleral veins, and that is called as the uveoscleral outflow. So we have two outflows. One is the trabecular outflow, and the other one is the uveoscleral outflow. So the rate of secretion at a time is equal to the rate of absorption, and there is never a buildup of the fluid in this anterior chamber. Now, what happens in glaucoma is that there is some problem either with the secretion of the drug, either it is excessively secreted, or it is facing a decreased absorption. So, or maybe there is an obstruction in this area which is not allowing the fluid to come out and is building up within this area. And whenever it starts building up within the anterior chamber, there is increased intraocular tension. And in case it builds up too much, it can press upon the lens, and the lens will press upon the vitreous humor behind, and the vitreous humor will press upon the optic nerve behind and can lead to loss of vision. And that is why it is so important to control this and to manage this condition. So here, when you see in the previous case, you are giving this patient of an open angle glaucoma a drop called temolol maleate. What is open angle before that? Let's see. Open angle is when the iris and the lens is allowing a proper route for the fluid to flow. That means there is no obstruction at this point. There might be a problem in the trabecular meshwork, there might be increased secretion. There is no problem at the outflow. The outflow is normal. And in angle closure glaucoma, there is an obstruction here at the level of the iris and the lens. There is a little area for the fluid to go, and that is why it starts building up over here. So that is angle closure glaucoma. So in this case, which we are dealing with is an open angle glaucoma, means there is no obstruction, and you have to just take care of the secretion or the absorption, right? So what is temolol maleate? Temolol, if you understand lol, it is a drug which is a beta blocker, right? So is it a selective or a non-selective one? Yes, it is a non-selective beta blocker. That means it is a beta 1 as well as a beta 2 blocker. Now, what is the pharmacotherapeutic part of timolol? It is the beta 1 blockade which is pharmacotherapeutic. Why? Because again, if you see in this diagram, you can see the site of action of beta blockers. What it does is it reduces aqueous secretion by the ciliary body by its beta 1 action. So, beta 1 action will reduce secretion of ciliary, say aqueous secretion will be reduced. So once the aqueous secretion is reduced, there will be no buildup of any aqueous humor here and the intraocular pressure will come down. So that is basically how beta 1 blocker timolol works. But now because it is a non-selective beta blocker, there is something in addition which is coming here, that is the beta 2 blockade. And you need to know that what is the function of beta 2. Beta 2 at one place it causes bronchodilation, right? It causes bronchodilation. So in your lungs, there will be lesser obstruction to the airflow. So one function of beta 2 is bronchodilation. The other thing is beta 2 is involved in helping reversal of hypoglycemia. It helps reversal of hypoglycemia. How? Because it causes glycogenogenesis. So gluconeogenesis. So this is how it increases glucose and helps to reverse hypoglycemia. It helps in whenever you have a sudden hypoglycemia, beta 2 helps in reversing. So this is one of the case. And that is why when you are having this additional action of beta 2 blockade, there is reversal of these functions. There will be bronchoconstriction instead. There will be hypoglycemia instead. It will not help in reversal. It will not help in bronchodilation, and you can have breathing abnormalities. In a patient who is asthmatic, he might face breathing abnormalities. In a patient who is a diabetic, he might face difficulty in correcting his hypoglycemia in case he develops hypoglycemia because of his insulin therapy. So that is where you have to be careful with the timolol eye drops. And this action will be seen only if the drug comes from the eye into the systemic circulation. And why would the drug come into the eye, from the eye into the systemic circulation? What is the connection? So if I draw here the eye, okay, here is the eye. This is the other eye, I'm sorry. And this is the nose. So when you're giving the eye drop, you just want the eye drop to be within the eye and to function within the ciliary body and to reduce the secretion. But in case it travels via the nasolacrimal duct and comes into the nose, it is then absorbed from the nose into the bloodstream. From the nasal mucosa, it is absorbed into the bloodstream, and now it can bring about these side effects of bronchoconstriction, of hypoglycemia, accentuation. So that can be prevented by applying pressure. You will ask the patient that after you put the eye drops, apply pressure here, apply pressure here at the inner canthus so that absorption is prevented, so that there is no absorption into the lacrimal duct and the drug stays in the eye. To prevent that, you apply pressure over the inner canthus with your fingers. Okay, so now you've understood that what all it is going to cause and how it is going to affect. Let's see the instructions I've written down here for you. So, first of all, you will be explaining to the patient what his condition is and why you are giving this eye drop. It is going to reduce the intraocular pressure in your eye. Alright, now the instruction regarding the use. Regarding the use, you will tell that before using those eye drops, shake that bottle and put this Timolol eye drop twice daily. Take it once in the morning and once in the night. So you have to tell about what frequency, when to take, how to take, and then apply pressure on the inner canthus after each eye drop for 5 minutes. You have to apply the pressure on the inner canthus, close your eyes, and wait for 5 minutes before you apply the drop to the other eye as well. Okay, then you'll tell the side effects such as mild stinging, redness, dryness of the eye can also occur within the eye. So stinging, sensations, redness and dryness of the eye can occur, which is normal. It will subside after the treatment. And this is a note for us, as I told you, in asthmatics and diabetics, we have to be careful. We have to ask if they're taking any other drug together so that there is no concurrent side effect. For example, beta blockers, as you know, beta 1 blockers decrease the heart rate. And this patient, suppose, is also taking verapamil. Verapamil also decreases the heart rate, and there will be a very drastic decrease in the heart rate together. So you need to know if any other drug is taken together and if there is a possible interaction, then you have to manage that as well. Okay. So here comes the case number 2, which says that you have to provide instructions for a 35-year-old patient with hypertension who is prescribed tablet atenolol, 25 mg. So it is a hypertensive patient and you have to prescribe atenolol, give instructions. So now you know that atenolol again is a beta blocker and it is a selective one. It's a beta 1 blocker only. And that's the exact function we are looking for, because this is going to decrease the heart rate, decrease the cardiac output and decrease blood pressure as well. So that is how atenolol is approached. Now, because beta 1 blocker also come with some CNS side effects like sedation and CNS side effects. It's not a function, it's the side effects. Sedation, sleepiness, and tiredness, which is one thing you need to inform the patient about. Otherwise, there is nothing as specific instruction for atenolol as it was for timolol here. So now the other instructions which come along with this is the general instruction for any hypertensive patient regarding his diet, regarding exercises and all. So we'll just read it out from here in the instructions. You will just tell him that you have been diagnosed and which is a condition with increased blood pressure, and I am prescribing this drug which is going to control your blood pressure. Okay, you must take it. This is the specific instruction: one tablet of atenolol in the morning daily. You are prescribing this one for 1 month now, because you might want to assess the patient after 1 month and see if the drug is specifically helpful in this patient, or you have to change. So that's for 1 month you're giving. You also need to tell again, see the warning that this drug has to be taken for 4 to 6 weeks before its action becomes evident. So don't stop it in between. Okay, do not stop the medication on your own, because it requires long-term treatment, and stopping the treatment will result in complications. As I told you, that hypertension can cause organ damages. For example, the kidneys and the heart, the blood vessels can be damaged. Now, the specific side effect of beta blockers, as I told you, is sedation, sleepiness, and tiredness, which you will inform the patient that this might cause minor degree of sedation and sleepiness. Do not um, worry about that, but definitely take care when you're driving. Maybe don't drive, or take care when you're driving in such a situation. When you've just taken the drug, maybe don't even try to drive. Now, reduce the amount of salt. This is the dietary instruction, and whatever foods you have to take rich in polyunsaturated fatty acids, etc. And then you might ask the patient to do regular exercises, avoid smoking and alcohol, and review after a month. So that is the general uh, instruction. But this basic specific instruction for atenolol here you remember is you have to take it in the morning for a month, and these are the specific side effects. And the rest all comes with any antihypertensive drug, any hypertensive patient, you have to instruct with these general instructions. Okay, so here let's come to the third sample case. Okay, so the third sample case is instruction for a 55-year-old newly diagnosed hypertensive patient who is prescribed tablet enalapril. Enalapril. If you see the prill here, you can get an idea that this is an ACE inhibitor, right? An ACE inhibitor, and it is used in case of an hypertensive patient. So what is the mechanism of action of ACE inhibitor? As it says, it is an inhibitor of the angiotensin converting enzyme. So it acts on the RAS system. It inhibits the angiotensin converting enzyme. It does not allow angiotensin 2 to form, and when angiotensin 2 is not formed, angiotensin 2, which causes vasoconstriction and hypertension, is stopped. There will be no hypertension, and because also angiotensin 2 was causing aldosterone secretion, there is no aldosterone secretion, and therefore there is no sodium or water retention. That's how the BP comes down, right? So any prill comes here, it's an ACE inhibitor. Now, whenever it comes to ACE inhibitor, one specific side effect which should come to your mind is about the bradykinin. The bradykinin related side effects of cough, angioedema. Okay, cough and angioedema which comes into your mind because ACE was also responsible for breaking down bradykinin into its inactive metabolites. But when ACE is inhibited, the bradykinin also starts accumulating, and then that causes cough and angioedema. So that's all very specific instruction regarding enalapril, because there is no other such specific instruction for enalapril otherwise, and because again it is an antihypertensive drug, as atenolol, the previous instructions will go the same for this drug as well. So here, let's read them out. You are again informing the patient about what he's diagnosed with, and you're telling him that now I'm prescribing you a drug called enalapril, which is going to keep your blood pressure in control. And you don't need to tell him the mechanism of action definitely, because it's not telling you that um, there will be increased urination or stuff like that. So the patient will not even be worried about the mechanism of action. And here we'll tell them that it's to be taken 5 mg, it's to be taken every day once in the morning after food. Okay, that's the thing about the absorption. Do not stop the medication on your own again, because it is an antihypertensive drug. It requires a long-term treatment and it can result in complications if you stop it and the BP is not controlled. And now the specific instruction for this drug comes in, which is you might experience dry cough, dizziness, or skin rash because of all those bradykinin related metabolites, right? The bradykinin which is accumulated. So if that happens and it's excessively disturbing to you, come back to me, report it to me immediately. So maybe because you will change the drug. When what do you change the drug to? You change it to something called as angiotensin receptor blocker. Come back to this mechanism of action. So angiotensin receptor blocker blocks this receptor at which angiotensin 2 works. It does not block the formation, it blocks the receptor at which it works. And this is how it will also help in a similar manner. So if in case ACE inhibitor is not tolerated by the patient because of excessive coughing and angioedema and stuff like that, you can change it to an angiotensin receptor blocker. Okay, then the general instructions for an antihypertensive drug के साथ जो आते हैं वो यहाँ पर भी आएंगे. So what are those? You will tell them to reduce the amount of salt intake. You will tell them for healthy foods to reduce oil but to increase polyunsaturated fatty acids, and to do exercises, avoid smoking and alcohol consumption, etc. So that's the general instruction, and you will ask the patient to come back after a month so that you can review the patient and see if the drug can be continued or anything else needs to replace it, right? So now here. Alright, so here comes the case number 4, which says you to provide instructions for a 45-year-old patient with a history of acute angina regarding the use of sublingual tablet isosorbide dinitrate, 5 milligrams. So what is angina? Yes, angina is chest pain. And why does that happen? It happens when the blood supply to your myocardium is compromised. So the blood supply is reduced to the myocardium is facing ischemia, and that is why you start experiencing chest pain. And the treatment for such a case is isosorbide dinitrate. Now, for acute angina, there is a use of sublingual tablet isosorbide dinitrate, which is used 5 milligrams dose. So nitrate enters the blood vessels, smooth muscle cells. It does not enter into your myocardial cells, but it enters the smooth muscle cells of your blood vessel. Now, once it enters the blood vessels, it gets dilated. It gets denitrated to release something called as nitric oxide. Nitric oxide is a stimulator of guanyl cyclase, which increases the level of cyclic AMP. You can see here, cyclic AMP goes high. Cyclic AMP inhibits phosphorylation of myosin light chain kinase MLCK, and when this happens, it inhibits contraction of the smooth muscle cells. That means it causes their relaxation. Now, when it causes relaxation, it will basically cause the blood vessels to dilate, right? So then these smooth muscles, when relaxed, cause blood vessels to dilate, and the blood supply to the myocardium is resumed. It is re-established, and the myocardium will not get ischemic. The ischemia is reversed, and the pain is resolved. That is, the angina is resolved. But you also need to understand that this nitric oxide is not specific to the blood vessels of the heart. It is also going to dilate the blood vessels of your entire body. So the systemic dilation is also going to happen, and when this systemic dilation happens, it decreases the blood pressure overall in your body. And that is the major side effect. The blood pressure will fall. It's not actually the side effect, because in heart failure cases, we actually want the blood pressure to go down so that the body is relieved of the preload, and thus also the afterload by decreasing the vasoconstriction. But when you're taking it suddenly and the BP falls suddenly, you might fall because of dizziness, and that's the important instruction the patient has to know. So let's see here, what are the instructions to be taken. The first thing is you are going to tell the patient to sit or be in a lying position when you take the tablet sublingually. Sublingually is also important because in an acute condition, you want the drug to be absorbed quickly, and it gets absorbed quickly from the sublingual area, and also it is prevented from the first pass metabolism. So to bypass the first pass metabolism, bypass first pass metabolism, you want the patient to take it sublingually. Now it won't go to the liver, it won't get metabolized over there, and it will reach the blood vessels, it will reach the heart, and will bring about this effect quickly. And take it in a sitting or lying position. Why? Because we don't want the blood pressure to suddenly fall and the patient might fall. Okay, the patient might fall because of the sudden fall in BP. So to prevent that, we ask the patient to take it sitting or in a lying position. The second thing we instruct the patient is that once the pain subsides, just spit the drug out, spit the remaining drug out. Why? Because once the pain has subsided, that means the action has been achieved. That means the coronaries have dilated, and the myocardium has resumed of its blood supply, has been re-established of its blood supply. So the remaining drug, you don't need it, otherwise there will be excessive fall in BP overall, and you don't want it. So you just want to spit the drug out, whatever is remaining in the mouth. The third thing is you'll tell about the specific side effects like headache and flushing might happen. Now, why would he face a headache or flushing over the face? Flushing is because the subcutaneous vessels over the face will dilate, and that will cause redness over the face. Why headache? Because vessels in the meninges may get dilated, and when we press upon the meninges, you know that the meninges are pain sensitive substances. The dura is the pain sensitive structure. So, those blood vessels will push upon the dura and will cause headache. Okay, so that is one of the important side effects with nitrates. And we tell them not to take with any other drug of erectile dysfunction. Now, this is very important. Why erectile dysfunction drugs are contraindicated with this? What do you know about erectile dysfunction drugs? Do you know the names of these drugs? Those are called sildenafils and tadalafil. Do you know that? Sildenafil. Now, what do these drugs do? Sildenafil, the mechanism of action is that it is a phosphodiesterase inhibitor. Phosphodiesterase. That means there is an enzyme, this enzyme is actually causing destruction of cyclic GMP and cyclic AMP. Cyclic AMP. So in the previous diagram, if you remember, the cyclic GMP goes high, and that is how contraction is prevented, right? Ultimately, the myosin light chain kinase is not phosphorylated, there is no contraction, and the smooth muscles relax, there is vasodilation. Similarly, sildenafil being a phosphodiesterase inhibitor, it does not allow cyclic GMP to break down. So ultimately what will happen? Cyclic GMP will increase, there will be no phosphorylation of myosin light chain kinase, and finally there will be vasodilation, smooth muscle relaxation and vasodilation. So again the same effect ultimately. So the same effect is brought about with sildenafil along with nitrate, and there is an additive effect can very significantly reduce the blood pressure to a very low value, and that can be very dangerous for the patient. And that is why you ask the patient not to take with a drug for erectile dysfunction, for example sildenafil, or any other blood pressure lowering drug. Okay. Okay, so here comes the sample case number 5, which is for a 45-year-old patient with heart failure who is prescribed tablet furosemide 40 milligrams. So in patients of heart failure, basically, there is decreased capacity of the heart to pump the blood, and so your prime approach is to reduce the volume in the vessels, the intravascular volume, so that there is decreased preload in the heart, and so more better contraction is achieved. So this is furosemide. It's a high ceiling diuretic. Acts on the NKCC2 channel on the ascending loop of Henle. So it is a high ceiling diuretic. It causes loss of sodium and potassium. It causes loss of water along with that, and that is why it causes hypokalemia as well, right? Hypokalemia, because potassium is lost. So basically what you need to know that it is a very strong diuretic. It can cause significant reduction in the blood volume. It reduces and it takes care of the pulmonary edema very well, and because it causes hypokalemia it can cause muscle cramps. So that basically which all specific dealings with this specific drug, and other instructions will go with respect to uh, the side effects. So let's read them out quickly. Uh, we are telling the patient why we are giving them furosemide, because it will excrete excess water and sodium from your body by increasing the urine production. So it will help your heart to function better. So you have to take this drug 20 milligrams every day, twice, once in the morning, once in the afternoon with meals. That means there is no significant interaction with meals. You can take it with meals. Now, you might notice that you urinate more frequently, right? As I told you in the initial examples, that you might have to tell this patient that you might urinate more frequently, so that is normal. Just take care not to take the dose uh, not to take the dose after 4 p.m. Take it before 4 p.m. That is why you're giving it once in the morning, once in the afternoon. Because if you take it after that, you might have to wake up during your sleep for urination. So, not to get disturbed in your sleep, take it before 4 p.m. And if you notice any muscle cramps and excessive fatigue, that is because of hypokalemia, and excessive fatigue because of excessive blood loss, or excessive fluid loss, report to me immediately. Otherwise, mild muscle cramps is okay. Now, this is because of excess action of the drug, right? When there is excessive action, there will be excessive action of the drug, there will be muscle cramps because more potassium is lost. Excessive action of the drug, there will be more fluid loss, and these are the side effects because of excessive action. Now the next side effect, which is edema or dyspnea, is because of improper action. What do you mean by improper action? That means the drug is not able to function properly. It's not reducing the fluid as much. It is not reducing the pulmonary edema as much, right? The fluid is not lost as much, and that is why you have edema, you have dyspnea. So that means the drug is not working for the patient. You will have to assess the patient again, see if the dose is proper, see if the patient is taking the drug or not, and stuff like that. So here you are telling the patient to take care of the excessive action as well and the lowered action as well. If it happens, then you have to come back to me immediately. Now, do not stop the medication on your own because it also requires a long treatment. Stopping will result in problems. And the other general instructions, just take care of your diet, reduce the amount of salt intake, avoid smoking, do exercise of mild to moderate intensity, and come back after 2 weeks or 3 weeks. Alright, so this is the sixth sample case, which is for a 35-year-old female with iron deficiency anemia who is prescribed tablet ferrous sulfate, 200 milligrams. So, with respect to ferrous sulfate for a condition like iron deficiency anemia, there are a few peculiar points that you need to instruct the patients on. The first thing is regarding its absorption. So there are a lot of things which impede the iron absorption, and you have to tell the patient to take this drug before the food ideally, or after the food if the patient is experiencing a lot of gastric symptoms like gastric upset, bloating, and pain in the stomach, etc. So the patient can take it after food. Otherwise, it has to be taken before the food, but never with the food. Mind my words, never with the food. Why? Because if the food contains egg yolk and stuff like phosphates and maize and wheat, which contains phytates, or if it's taken with tetracycline antibody or any other food, or something like an antacid. Antacid, why antacid? Let me tell you that. Because iron is basically absorbed in the ferrous form. Ferrous form. But in case if some amount has been oxidized to the ferric form somewhere in the stomach, maybe it has to be reduced back to the ferrous form to be able to be absorbed at the level of the duodenum. That is where iron gets absorbed, at the level of duodenum. So it has to be in the reduced state, and antacids and alkalis will prevent reduction of iron and prevent absorption thereafter. So alkalis will prevent its reduction to ferrous form, and that is why alkalis are not to be taken. Instead, ascorbic acid, vitamin C, and stuff like that can enhance absorption of ferrous because they enhance reduction to ferrous form and hence enhance the absorption. So remember that alkalis, phosphates, phytates, tetracyclines can interfere, and that is why you ask the patient to take it before food or after food, depending upon the side effects, and never to take it with the food. That's the first thing. So, regarding the absorption, that was the first thing. The second thing is that at any time, not the entire dose of iron sulfate is going to be absorbed. Not the entire dose of ferrous sulfate is going to be absorbed. Some amount will be lost in the stools, and this will appear as black stools. So the patient has to be informed that yes, you might notice black stools, but that is not a point to worry upon. It will get normalized once the treatment is over, and it is completely normal. The second thing was black stools. And the third thing is, even after maybe a 1 month or a 2 month therapy, you will bring about the complete blood reports again, and you will find out that when the doctor will find out that the patient has improved upon its anemia and the hemoglobin has almost come to normal, the patient will still be told to continue the drug for 3 more months or 2 more months. That means that is actually to replenish the stores, and that is why even after the anemia is corrected, you don't have to stop the drug. We will also have to replenish the stores of iron in the body, and that is why even after the correction of anemia, we might continue the treatment for few more months. Okay, so these are the three important points on which the patient will be instructed. So let's go and read it out. The first thing is you're telling them that you have been diagnosed in anemia, which is because of iron deficiency, and that is why I am going to prescribe you iron tablets. Now, when to take it, the instruction about the usage. Take one tablet, preferably in an empty stomach, right? An hour before the food or 2 hours after the food in the morning. Why before the food? Because you don't want any interference. Why after the food? Because the patient might be experiencing excessive symptoms of abdominal pain, heartburn, and stomach upset. So then you can take the tablets after the meals, but never, never, never with the meals again. Take the dose at the same time every day. If you forgot to take the dose, leave it and continue to the next dose. But don't take two doses together at the same time or very close to each other. Okay? You will tell not to consume antacid tablets because that will not allow proper absorption. You tell the patient not to. This medication can cause darkening of the stools, so which is not at all harmful. It will also cause some slight stomach pain at times, so that will be normal. Don't worry about that. Now, if you have severe abdominal pain or blood in the vomitus, please visit the hospital immediately. If there is some severe abdominal pain or blood in the vomitus, there is excessive side effects, then you have to come back and visit the hospital immediately. Okay, and also, you have to increase iron-rich foods. There is green leafy vegetables which are rich in iron, peanuts, jaggery, etc. And follow up with a hemoglobin report after 3 months. We'll be checking the hemoglobin reports and see if we have to continue to replenish the stores. Finally, I'd like to add a few more important instructions regarding two most commonly used therapeutic approaches. One is about the oral rehydration solution, and the second is usage of omeprazole for acidity as an antacid, right? So the first one is oral rehydration solution. This is specifically given in cases of dehydration because of maybe vomiting or because of diarrhea, right? And in these cases, what it is observed mostly is that we have this entire sachet of this oral rehydration solution powder, and if the patient is not properly instructed of how it is to be used, what they do is they might use a one spoonful of this powder into some indefinite amount of water and make the patient drink, but that is not the proper use of oral rehydration solution. This entire powder is meant for maybe a liter, depending upon the preparation, a liter of water. And so you have to add the entire preparation into a properly boiled and cooled 1 liter water, and this entire preparation now comes to that proper osmolarity, proper concentration, and then this is to be drunk within 24 hours ideally. So this is the instruction that the patient has to be given, that you cannot use any amount of powder with any amount of water. There is specific instruction of using this complete sachet of oral rehydration solution powder into a completely properly boiled 1 liter water and to be drunk within 24 hours ideally. Okay, that's about oral rehydration solution. Coming to omeprazole. Omeprazole is a proton pump inhibitor drug which is used in cases of gastric ulcer diseases or gastric esophageal reflux diseases, etc., whenever there is increased acidity. So, how does it function? Let me tell you about its mechanism of action in brief. Is that omeprazole is actually a inactive drug, and it gets activated only at a pH less than 5. Okay, it gets activated only at a pH less than 5. And when it gets activated, it quickly binds with its target protein and brings about the action. What is its action? It is a proton pump inhibitor. So it is going to inhibit the proton pump. Now what happens if you take it orally? If you take it orally directly, it will come inside the stomach, and because of the acidic pH, which is less than 5, it will get activated there itself and will not be able to function because its site of action is in the parietal cell and not in the stomach lumen. So it should be able to reach completely into the parietal cell and should not get activated and destroyed within the stomach lumen. So what do we do then? we get it into an acid resistant coating. It is covered in an acid resistant coating, and then it bypasses the stomach, it reaches the duodenum, it reaches there. From there it is absorbed into the bloodstream. From the bloodstream it will reach into the parietal cell, and there in the parietal cell it will inactivate the H plus K plus ATPase pump, which is nothing but the proton pump, the H plus K plus ATPase pump. And when the H plus K plus ATPase pump is inhibited, it will be reducing the acidity in the stomach, and this is how you will be relieved of the peptic ulcer symptoms or whatever gastroesophageal reflux symptoms. Okay, so because we don't want this drug to get inactivated in the stomach lumen itself, we want the stomach to be in an inactive state at that time. That means there should be no H plus secretion, or should be very less basal secretion of H plus. When is that possible? When the food is empty. When the food is empty, H plus K plus is working very slow. When the stomach is empty, H plus K plus is working very slow, and so the drug will be able to bypass the stomach and completely reach into the bloodstream. Now, once the bloodstream, when the drug has reached the bloodstream, you will ask the patient to now take the food so that this pump starts working. And when the pump starts working, there is acidity in this area of the canaliculi of the parietal cell, and this drug will reach in this part of the parietal cell. It will get activated and will inhibit the proton pump. So it is important that the proton pump inhibitor gets activated, and it will get activated only after it reaches the parietal cell if you take the food after taking the drug. So that is how the instruction for omeprazole goes, that first you don't have to take the food, let the stomach be empty, take the drug, and after half an hour take the food, and now it will be able to pump the parietal cell H plus K plus ATPase pump. So that was the first point about its activation in the acidic environment. The second point is that it inhibits CYP2C19. It inhibits CYP2C19, and that is why it has a few more drug interactions. It can increase drugs with low therapeutic index, which are metabolized by CYPs, like warfarin. Warfarin gets increased if it is taken together. Phenytoin can get increased, and these drugs are with low therapeutic index. They can be harmful if they're in excessive concentration in the body. And that is why we cannot take omeprazole and these drugs simultaneously. There should be a gap, or we cannot give a drug to such patient. Also, if these patients are on clopidogrel is an antiplatelet drug which is used after MI in patients as a prophylaxis to prevent further MI. So in myocardial infarcted patients previously we give this drug, and this drug has to be activated by CYP2C9. CYP2C19 helps in activation of clopidogrel. And if omeprazole is given simultaneously, it will inhibit CYP2C9, and that is why there will be no activation of clopidogrel, and clopidogrel will not be able to function. So even omeprazole cannot be given to patients who have clopidogrel, who are on clopidogrel prophylaxis, or there should be a proper maintenance of gap between the two drugs. Okay, so these are a few instructions regarding omeprazole. So, this was all about the basics of doctor-patient communication and its application in clinical pharmacology. I hope it was helpful. Thank you.